You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 27th, 2017. This week I have two stories on statins, high-sensitivity troponin, his bundle pacing, and a consensus statement on the treatment of mitral regurgitation. First up, the statins and diabetes study. Several randomized controlled trials, RCTs, have reported an increased risk of type 2 diabetes with statin therapy. But most of these studies enrolled patients at relatively low risk of diabetes, and the incidence of diabetes was self-reported. A new analysis in patients who were at high risk of developing diabetes has confirmed this association seen in previous studies. The strength of these findings in the present study are bolstered by the fact that the diabetes was rigorously detected with oral glucose tolerance testing and semi-annual fasting glucose measures. In this analysis, authors analyzed data from the BPP study, which was a previously published RCT of more than 3,200 patients which compared lifestyle intervention, metformin, or placebo for the prevention of type 2 diabetes. The original BPP study was published in 2002, and this analysis looked at 10-year follow-up of patients from this trial who received statins versus those who did not receive statins. And they found that statin use was associated with a greater diabetes risk irrespective of treatment groups, lifestyle or metformin, and the pooled hazard ratio was 1.36, highly significant. The risk was not significantly altered by adjustment for the baseline diabetes risk factors. Now, this risk is higher than previous studies that looked at the diabetes-statin association. For instance, in Jupiter, the hazard ratio of developing diabetes on statins was 1.5, and in a meta-analysis of 6 statin trials, the hazard ratio there was only 1.13. So 1.36 is pretty high. Now, the mechanism for the diabetes-statin association is speculative. Perhaps the statins uncover diabetes in high-risk people. The authors speculate that statins may accelerate the typical glycemic deterioration rather than exert a unique statin-specific mechanism. The big question is how significant of an effect is this clinically? Now, Dr. Richard Lehman, who writes for the BMJ, feels that the diabetes risk of statins is merely an artifact of how we measure diabetes and is not clinically significant. He argues that statins improve outcomes in diabetics. Now, I would say more about this analysis. This is a post hoc analysis of a study in which statin use was not randomized. I hate not taking a stand, but this is an area of uncertainty, and we need more data on the long-term risks and associations of statins and diabetes. More studies like this, particular one that had 10-year follow-up. The second statin study is interesting. Now, this was a 10-year-long pace control study from Denmark, and it looked at the possibility that statins could reduce the risk of community-acquired Staph aureus bacteremia. The Mayo Clinic proceedings published the results, and about 2,600 cases of bacteremia were compared to 26,000 matched controls in northern Denmark. Compared with non-users, current statin users experienced a decreased risk of Staph aureus bacteremia, and the point estimate of the odds ratio was 0.73, and again significant. Strengthening the association here were findings that the Staph aureus risk decreased with increasing intensity of statins, with the lowest risk of bacteremia and the highest dose of statins. So the more statin drug you took, the less the risk of bacteremia. In the discussion section of the paper, the authors put these findings in context, namely that there are signals from previous studies suggesting that statins may have a protective effect for infection. Some of these studies were post-op studies. They also speculate on mechanisms of why this would be. And again, it could be multiple different mechanisms of why statins could reduce infection. Although this is an interesting finding, the authors do have a quite long paragraph on limitations of this uncontrolled retrospective observational trial. I feel the most likely explanation of the association may be a healthy user effect or healthy user bias. And that is that infections were lower in the statin group because healthier, more robust people take statins. Nonetheless, we'll look forward for more studies in this area. The next topic has to do with high-sensitivity troponins. The problem with troponin testing these days, when it's used for the detection of MI, is that as the troponin test gets more sensitive, it becomes a less useful test clinically. Now, maybe in the future, biomarkers like troponin won't be used as a binary rule-in or rule-out distinction like it's used now for MIs. Maybe in the future, high-sensitivity troponin can be used alone or in combination with other biomarkers to prognosticate risk. Maybe a series of biomarkers will give us a better CHA2DS2-VASc score, for instance. Jack has published a large and rigorous observational study from Swedish registries looking at high-sensitivity troponin in patients who present with chest pain but had MI ruled out. So these were not myocardial infarctions. They had almost 20,000 patients in their study, and the mean age of the patients was about 54 years. These patients had elevated but stable troponins, not in the MI range. There was a graded risk depending on troponin level from less than 5 to greater than 50. The authors found this strong and graded association between all detectable levels of high-sensitivity troponin and risk for MI, heart failure, and cardiovascular, non-cardiovascular mortality. The problem with this analysis is, despite the author's rigorous attempt at excluding patients with reasons for high troponin, say end-stage renal disease or true myocardial infarction, is that high troponin also significantly associates with non-cardiovascular mortality. Let me repeat that. The high-sensitivity troponin also significantly associated with those who died of non-cardiovascular causes. So my question is, high-sensitivity troponin in these sorts of observational analyses just a marker of a sicker patient? Is that potentially an important thing to know? So the problem with this sort of data that shows that higher risk with higher troponins is that it can easily be translated into the real world. Diagnostic and therapeutic interventions in these patients will reduce the bad outcomes. And that's a leap of faith that we should not make until there are randomized controlled trials of interventions. Next topic is His bundle pacing. More evidence on the potential of His bundle pacing arrived this week in Heart Rhythm Journal. This study was a multi-center observational series of 106 patients who had His bundle pacing for reversal of left bundle branch block in patients who had either a failed LV lead as part of a CRT or as a de novo strategy for CRT. 90% of patients in this multi-center series had successful His bundle pacing. Over 14 months follow-up, both groups had significant QRS narrowing, get this, from 157 milliseconds down to 117 on average. They had improvements in ejection fraction on average from 30 to 43%, and they also had improvement of functional class from 2.8 down to 1.8. The group reported 7 of the 106 patients had lead complications. I think this study heralds the beginning of an era of disruption in pacing. His bundle pacing, these authors found, was safe and feasible, and the data came from multiple centers. The His bundle pacing was used both as a primary instead of CRT or as a bailout strategy when one couldn't find a good LV vein. There was documented improvement in cardiac function. Now, I try to do His bundle pacing now as a primary strategy in CRT patients. So if I have a patient with left bundle referred for CRT, I start with the His bundle and can reverse it in maybe not 90% of cases, but the majority. When His bundle pacing works, the QRS narrows to a degree that you won't see with CRT. It's unbelievable. It's amazing. And yes, of course, there is much to learn. We need to know about long-term performance of the His lead. Will the left bundle branch block reversal remain steady over time? After I've done about 65 cases, I can report that it's not hard to capture the His in patients with a pacing indication, say heart block or sinus node dysfunction, but I have to say it's a little lower than the 90% for reversal of left bundle branch block. I think we need better tools. I would like to see different size sheaths. For instance, there's only one preformed sheath right now. The other issue I'm concerned about is battery longevity, because often with these higher thresholds, you have to pace with a higher amplitude in the His channel. Nonetheless, this is an exciting area of cardiac pacing. Finally, The last topic today is that the ACC has released a consensus statement on the treatment and evaluation of mitral regurgitation. Like most of these consensus statements, this one is comprehensive and I learned a lot from reading it. I'm interested in mitral regurgitation because I believe it's an area of overdiagnosis and overtreatment. The document would be impossible to summarize, but many of the lessons that I learned from Dr. Feigenbaum at Indiana University back in the 1990s still hold true and were emphasized by the consensus writers. For instance, the authors emphasize that color flow Doppler can often overestimate MR. Gosh, do I see this often in my institution. The authors writing, this is their words. They say, quote, "It is crucial to record blood pressure, estimated LV systolic pressure in the presence of AS or LV outflow tract obstruction. Crucial to measure heart rate and rhythm at the time of the echo to incorporate them when grading MR severity." I am not sure that this is done routinely in most echo reports. I also like this comment from the authors and note their passive voice. Quote, "It is recognized that most physicians interpreting an echo look at color flow Doppler to identify the presence of MR and form an initial impression of its severity. Quote, "This assessment should be considered only a starting point that requires further confirmation using a Bayesian approach that integrates multiple factors to arrive at a final determination." The authors also tell us that quantitative parameters like EROA, or effective regurgitant orifice area, and regurgitant fraction also have technical limitations and imprecision which, quote, "should be considered in grading MR." Finally, another recommendation I was drawn to was the fact that, quote, "MR severity is notoriously dynamic." Gosh, that is an important clinical point. The document also goes into the identification of primary MR that is due to a valvular abnormality, or secondary MR due to dilation of the annulus from LA or LV dilation, usually from heart failure. The authors provide an equally good discussion of treatment options. These sorts of consensus statements are worth your time. They're well referenced, they're well written, they're comprehensive, and they have a ton of good information, and they also reiterate a lot of the things that we forget as we improve our technology. Some of these basic messages, especially about mitral regurgitation, are worth keeping in mind. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.